So anyway, without further ado, I'll hand over to Paul. Thank you.
Thank you. Thank you and welcome. It's great to see so many people here. And many thanks to Paula and Janet and Anand for organising my visit over here and this opportunity to talk to you about this research, which is essentially what I'd like to do today is present to you some of the findings and some of the outcomes from this research, mixed methods research that we completed in Wales through Swansea University in 2000 and towards the end of 2013. And really the title says it all. The research was looking at what does it mean to provide inclusive services to older people who identify as lesbian, gay and bisexual, specifically in care environments, nursing care, long-term residential care, and also including extra care facilities as well. And I just want to, there's lots of kind of brands and different names of different organisations up there. I just want to acknowledge a couple of organisations which supported the research. The first was the Older Lesbian, Gay, Bi and Trans Network for Wales, which runs through Age Cymru, and My Home Life Cymru. And I understand that you have a similar My Home Life program operating in Northern Ireland as well, so similar approach. And the research was funded by NISCA, which is a social care research funding body in Wales through the Welsh Government. Okay, and just to also acknowledge this was a group effort in our Centre for Innovative Ageing, and you can see at the bottom there all of my colleagues who are involved in the research, so I speak on behalf of a group today. Okay, so I want to talk a little bit about policy, particularly looking at the policy background in Wales, which frames this particular piece of research. Talk a little bit about approach to the research in terms of methods, talk through some of the key findings with you, and talk about what does this mean in terms of putting forward a case for change. So a good starting point is what do we already know? What do we already know from the literature, from previous research? And the ILC, amongst other authors, talk about the sexuality of older people in care environments being a last taboo. And we could debate that. You might think, well, I could think of other greater taboos around older people in care, but nonetheless, sexuality represents a very difficult and challenging topic, particularly when often older people seem to be stripped of their sexuality or perceived to be asexual or lacking any kind of interest in sexual relationships and intimacy. And then to break that down a bit more to people on the fringes around sexuality and sexual identity, there's been a lot of literature and research, mainly from the States and Australia and some in the UK, about the heterosexist assumptions and discrimination or homophobia that older LGB people can experience in care environments and services. So we've got that international landscape as well. Closer to home, this Stone recent project completed in 2011, and this was a significant survey because it compared a large sample of heterosexual older adults with lesbian, gay and bisexual participants over 55 years, and it found that older LGB adults are more likely to be single, to live alone and to have less contact with biological family compared to their heterosexual peers. And they also lacked a lot of confidence in accessing health and social care services, which of course then translates into them not accessing health and social care services. So a really important piece of research. The research focused on England, Scotland and Wales. It didn't encompass Northern Ireland, so just to acknowledge that there's a gap there. However, we didn't know a lot about, when we started talking about this project in 2011 with my colleagues at Swansea, we didn't know a lot about what would be the case in Wales for older LGB people in terms of long-term care and what are their experiences and how would they be treated or perceived by care providers and care home managers, which led us down this path of inquiry for this research. Just a little bit of policy, I mean just a tiny little bit. I won't talk for too long about policy, but just to recognise, I think we've got a lot of really good policy in Wales. It's very older people centred, it's also very human rights centred, and Wales has just introduced its own declaration of rights for older people. We've got a good strategy for older people in Wales which recognises sexual minority groups amongst ageing populations. and the National Service Framework for Older People in Wales, which again recognises the importance of anti-discriminatory measures in health and social care services. We also have a new bill, it's now Act, Social Services and Wellbeing Act, which really separates us from England for the first time in terms of social care and adult care delivery in particular. And Wales has taken up wellbeing focus, a holistic focus on wellbeing, and talking about wellbeing in a broader sense that recognise aspects like social and economic wellbeing, rights and entitlements, and physical and mental health and wellbeing. And I think this provides a really good platform to start talking about sexual health and sexual wellbeing, and to really expand on that. And of course we have the Equality Act, and in Wales, local authorities in particular have duties to publish objectives and strategies of how they're going to make sure that they are continually addressing equality and discrimination issues inclusive of sexual orientation. So I think we have a good policy landscape for building on this research and for changing practice in this particular area. A little bit of theory, and again, I mean a little bit. These are some of the kind of theoretical threads or ideas that informed our thinking about the research, particularly when we were pulling it together, looking at the data and starting to think about, well, what does this all mean? What are the messages here? We looked at this interest in this concept about heteronormative spaces from human geography and from queer theorists who talk about heteronormativity as a cultural set of assumptions about heterosexual roles and privileges across social and political life. So the ways in which heterosexuality is seen as naturalised as a privileged position is seen as a normative standpoint or a normal standpoint from which other sexualities kind of fade into the shadows. So we're interested in how care home spaces can be constructed or experienced as heteronormative spaces. And a big part of that, of course, is where lesbian, gay and bisexual identities or people who've experienced same-sex relationships are not recognised on the same footing or not recognised at all. We're also interested in the feminist framework around ethic of care, and those of you in social work and philosophy might be more familiar with this framework. But authors around this particular framework talk about care not so much as a role or an undertaking or a duty, but thinking about care as both a moral and a political practice and a contested practice. And Toronto in particular talks about 4 key elements that make up an ethic of care around attentiveness, responsibility, competence and responsiveness. And we focused in particular around the 2 elements of attentiveness and responsiveness. The ways in which people providing care are attentive and attuned to the needs and wishes of the person and their experiences of whatever pain or suffering or illness that they're experiencing, and the capacity to respond and respond appropriately and respond in a way that takes into account the carer's needs and wishes. So I'll come back to this when we get to the end, just to give it a bit more context, hopefully make a little bit more sense. But I couldn't come and do a seminar and not talk a little bit about theory. Anyway, approach to the research. So what was the research all about? Well, we had a research question, and our research question was, how are the sexual identities and relationships of older LGB residents perceived and supported in residential care environments in Wales? And there are 4 methods across this piece of research. We had a content analysis, which I'll talk a little bit more about shortly, of inspectorate reports of care homes produced by the Care and Social Services Inspectorate for Wales. And then we had a self-administered questionnaire where we wanted to find out, well, what are the views and experiences and attitudes of care and nursing staff and managers within facilities? And we incorporated a couple of already validated or existing measures to help us ascertain or gauge what the climate might be around professional and care workers' attitudes. So we used what's called an LGB cash scale, which is about heterosexual people's attitudes towards LGBT people, including trans people, and Ascast, which is a more broader measure about looking at people's understanding around sexuality and ageing, and again wanting to gauge people's attitudes towards sexuality and later life. And of course we wanted to hear from older LGB community members living in Wales. So we did a small series of semi-structured interviews just to gather their views, really focusing what their hopes and expectations might be if they had to move into care. So kind of in a hypothetical situation, how they'd expect to be treated, what their hopes might be in terms of the care that they receive. And finally, we did about 9 different focus groups with care staff, with a couple of groups of managers, and with advocacy groups and stakeholders. So really get a nice fuller picture for these different methods about, well, what's the landscape here in terms of care provision? And across Wales too, so we had groups in the north and south of Wales. So I'm just going to talk a little bit briefly about the content analysis. And it is brief reporting on this one, sadly. We did a content analysis of inspectorate reports. In Wales, and I'm assuming it's similar here, all inspectorate reports of care homes are public documents. They're available online. There's a public directory. If you've got a family member or someone you care for who's going into a care home, odds are you'll probably go and have a good look at some of those reports, and it can give you a good sense of the care or the standards of care that have been reviewed and reported. So we thought, well, how much is sexuality on the agenda or on the radar of the inspectorate and their staff? So we thought, well, let's do a content analysis where we did a random sample, 40% of inspectorate reports from those 2 time periods, 2009-10 and 2011-12. And then we established a set of key search terms to help identify, is there any discussion about sexuality, about sexual relationships, about LGB identities, about romance. We kept it really broad. And we basically found nothing. There was no discussion. It was glaringly absent and really wasn't reported or captured any way, shape or form about intimate or sexual relationships of older people in care facilities. Where there was discussions about sharing a room, for example, an existing couple moving into a home who wanted to share a room, it was framed in terms of risk control, so very medicalised, very much focused on managing risk rather than intimacy or respecting people's privacy and promoting the relationship. There were references to privacy and the importance of independence and dignity within care homes, and we'd expect that in terms of inspectorate's part of the policy framework, but none of these were related to sexuality or discussed in the context of sexuality. But I need to add a clause or caveat here. We've since spoken to the inspectorate. We presented the findings to them initially, and what seems to emerge that those discussions do happen as part of the review inspection process, but they don't get formally captured within the reporting. So I think we can't judge this organisational agency based on the report content alone, but there's clearly a gap there between the discussions that happen in the care homes with the staff, with the residents, and what actually then gets distilled into the reports. And the reports are getting shorter and shorter too, which is probably a good thing for the general public, but it just means that then things get squeezed out or left off the radar. So we then had a look at the questionnaire data, and this was piloted in 3 care homes, and then we rolled it out across, I think it was about 56 homes that participated. I haven't put it there. But a little bit about the participants. There are 121 people, care staff and managers, including nursing staff, predominantly white, over 2/3 Christian, predominantly heterosexual. Most were in care worker roles, so we're lacking more respondents from a nursing background in this sense, although it could be more that there's more highly likely there's more care workers in terms of ratio to nurses within facilities. Mostly female, and no surprises there, given the workforce demographic providing care. 63% private nursing homes, and just over 2/3 were people from Wales. They were born in Wales and they lived in Wales for a number of years. Who's missing? Ethnicity, okay. We have a very white population, very white sample here. And that really didn't tally up when we went into care homes, because we took the questionnaires over. We had a researcher on the project full time, and she would drive here, there and everywhere taking bundles of questionnaires into homes that agreed to participate. And we did focus groups in some care homes as well. And we could clearly see that there was a diverse group of people, diverse group of staff from different ethnic backgrounds. But that didn't come through the questionnaire findings. The first response is to think, well, maybe they didn't want to fill it in, but I think it's a much more complex picture than that, and I wouldn't want to start reaching unfair conclusions about people's ethnicity and willingness to participate. It could also be effective gatekeeping. The man just distributed the questionnaire. We weren't allowed to do it directly for ethical requirements and not to step on anyone's toes in terms of participating. So it may be that care home managers or people handing out the questionnaire just thought, that's a bit too hard. English isn't their first language, or they won't understand it. But nonetheless, they are a missing voice in this particular sample. Some of the descriptive findings from the Ascast scale. So this was a scale about knowledge around sexuality and ageing for older people in general, not necessarily inclusive of LGB sexualities, but not just about sexual minority individuals and communities. And good results. Most respondents held permissive, affirmative attitudes towards sexuality and ageing. So, for example, most respondents disagreed with these statements about they disagreed that sexuality declines amongst older people as people grow older. They disagreed about sexual engagement outside of marriage being immoral. And they disagreed that, for example, masturbation was harmful. So initial glance at these findings says, okay, here's a fairly supportive or permissive sample in terms of attitudes towards sexuality. Again, some positive results. Majority recognise the role of residential services in supporting sexuality and relationships. Just under 2/3 were supportive of integration amongst residents, particularly residents came from different sexual backgrounds or sexual identities. Majority were respectful of privacy and were willing to facilitate privacy, although that interestingly drops a little when it comes to having an active responsibility of facilitating privacy for couples who want to experience sexual relationships. Just over half were interested in training opportunities about changes in sexual functioning in older years. So that was less warmly received. Nonetheless, just over half the group were interested in that training and education. And 71% would support sex education for staff, which doesn't quite fit with the previous result. But interestingly, that drops down to just over half when we talk about sex education for residents. And again, I don't know whether that's because that's just one step too difficult or too challenging to then facilitate sex education, for example, with people in the home, the people that you're already providing care for. People were more cautious in attitudes towards sexuality where there were discussions about declines in mental capacity. And as soon as there was discussions about concerns over lacking mental capacity, particularly in the context of giving consent for sexual relationships, that was very much put in the risk basket. It was seen as a POVA issue, meaning an issue for local authority teams around the protection of vulnerable adults. It was seen as a all alarms blaring and ringing issue, more so than an issue that people would want to dwell on or explore in a bit more depth about what that could look like. For good reasons in terms of protecting people from harm, but very much seen as that's someone else's issue, that's an external agency's issue, that's a local authority adult care issue, and they'll come in and they'll deal with that, and then they'll tell us what to do. The second measure was around the LGB cash. So this is attitudes towards lesbian, gay and bisexual people, not necessarily older LGB people, just LGB populations in general. And again, some good responses in terms of respondents didn't consider themselves to be overtly homophobic or to hold homophobic views. Same time, they didn't feel knowledgeable about LGB history or symbols or community, although I have to acknowledge this measure does tend to have more American-based language, which is one of the issues of using an existing scale. You've got limited scope to tamper with the way that different items are worded. And this one, for example, talked about Stonewall riots. So we had to put in a similar example just to put that in context, in a UK context. And respondents were supportive for civil rights for LGB people, but there was more ambivalence when it came to thinking about conflict with religious views. And people were less supportive or less agreeable when it came to conflict with religion. We had one positive relationship, one significant relationship statistically, and we're still trying to puzzle it over, and maybe some of you will have some answers for it today. But the one positive relationship was about the longer someone was in post, they had an increased awareness of LGB issues and a decrease in homophobic attitudes. So the longer they were in post in the same agency, I think the question was over 5 years, they were more permissive and more positive. Not necessarily older, they've just been in post longer, so interesting. Anyone got any great ideas about that? Please put it forward, because we're still puzzling over that one. Okay, and on to the most important group here, the voices of people who could be potential service users of care homes. We had some interviews with 29 people who identified as lesbian, gay and bisexual, and they were between 50 to 76 years. These are people living in the community, living independently, about what their hopes and expectations might be. The one key finding that kept coming up time and time again, and we didn't necessarily ask for this, or this wasn't part of our interview schedule, was about the importance of LGB history and understanding how the history of criminalisation across the UK nations and the history of mental illness and medical pathology and homophobia continued to shape older LG people's perceptions of care services and professional services. Nearly everyone in this sample had experienced discrimination in some way, shape or form, whether it be in their local pub, within their village, through their neighbours, or with the example of Amy there. She was, this is the advice she received in 1970 from her psychiatrist in London when she was talking about the conflicting feelings she was having about her girlfriend. And the advice Amy received here was the psychiatrist telling her she shouldn't have these feelings and telling her to go ahead and get married to this chap and all this. And Amy says that's quite an incredible experience. So it's really important to recognise that shadow and legacy of history, particularly around criminalisation, and I'm aware that decriminalisation happened a lot later in Northern Ireland, so that's a longer shadow for more recent generations as well. And it also shapes people's willingness to have confidence and trust in organisations like health and social care services and care providers, which is no surprise really why they've got that Stonewall finding about older people's reluctance to access health and social care services. People were concerned about having to go back into the closet. And this isn't a new finding, it's been discussed for a long time about concerns about coming out in pivotal points in your life, turning points in your life, but then having to retreat back into hiding and conceal your sexual identity once you entered a care home because you were concerned about discrimination, homophobia. And Sarah, she was 59, she says, that would be the worst thing for me if you had to be completely in the closet with nobody knowing about you and you couldn't talk about your life. So really feeling like having to conceal all aspects of one's life, in which obviously sexual identity and previous relationships are an integral part. Most participants held some reticence or concerns about future discrimination and feeling vulnerable in care homes. It wasn't a place people wanted to go. Then again, if we ask Joe Blow on the streets if he wants to go into a care home, probably a similar answer. But intensified fears, particularly around fears around homophobia and discrimination, shaped, as I mentioned before, about those previous experiences of homophobia that most people in our sample experienced. The women in our sample spoke a lot about their fear of losing control, particularly if there were declines in mental capacity. So losing control over their appearance and how they're dressed, or how they prefer to be dressed, rather, in terms of self-presentation. So, for example, one woman was concerned she'd never worn a skirt or dress in her life, and she was concerned that all of a sudden she'd be put in skirt, dress, pearls, have her hair permed, have lipstick on, everything which was completely alien to her and just wasn't her personality or character in any way, shape or form. Annie held some rather grim concerns. She said, I'd be worried that as well to be somewhere where nobody speaks to you is a horrible thought, so that dread that you'd be isolated within the home and have no social contact. And Eleanor says that she thinks it's about being a woman and somebody of the same sex, she said, wouldn't want a man coming in to give care. And she thinks that's the same for a lot of women, not just a lesbian thing, but it's about feeling more secure with another woman as opposed to a man. So that was another key concern, particularly for women in the population, where a lot of the women in our sample spent most of their life now in contact with other women. There's very little contact within their social network with men. And suddenly they'd be forced into a home environment where they had to mix with men, live with men. One woman said, she couldn't dread having to get up and see some fella walking down the corridor in his pyjamas or something like that. It was just a completely strange situation to have to think about, and one which made people feel unsafe. People were concerned about being assumed straight and connected to that being separated from their partners. So this was another concern. If one partner went into a home and the other partner couldn't have regular contact or wasn't recognised by the care home staff in the way that they should be as a significant partner. This is particularly with partners where there was a significant age gap, and some of the men in our sample were concerned that their younger partner wouldn't get the recognition or treated seriously like they should, or they wouldn't have time together in terms of private space. So Paul here is 53, and he says he just wants people to treat him as my partner, as they would for a husband and wife, and acknowledge that really. And he's just really talking about wanting to have some privacy. Oh, and a cwtch, to say. A cwtch is a hug. It's Welsh for hug. We presented this in Sweden and we had to give a little demonstration halfway at this point. I can't do that up here, man. So they're very simple things about wanting privacy, but again, intensified when you're concerned that your partner is not going to be recognised by the home. And the importance of LGB communities and networks. And again, this isn't new finding. There's a lot of literature about the importance of recognising families of choice, a recognition that LGB adults may not have strong ties or relationships with biological family and may have more significant relationships and ties with non-biological significant others, or important people in their life. And again, a lot of the women we spoke to had lived in women-only networks for a long time, so this was really integral to them in terms of who mattered in their life. And interestingly, 50% of the group, so that's about 15 or so, were seeking LGB-specific residential care or gender-specific facilities. Other half, not so sure. The jury was out. Some people had reservations, some people were concerned that they'd be ghettoised or separated from other important people in their network, and other people said, I just couldn't think of anything worse of having to live with other LGBT people in the same space. But Nick, he was sold on the idea. He said, I'd be very comfortable going into a gay-run home where there would be gay people there, and it's something I'd very much like to do if there was an opportunity. I'd even go to London if there was an opportunity to do that. If I need to go into a care home, I'd go anywhere. And I think that's quite a sad statement, that last one, that people prepared to leave their community, their homes, their village, whatever the location might be that's become a meaningful part of their own life, simply to make sure that they do receive respectful and safe and dignified care. We spoke in the focus groups with stakeholders. A lot of the stakeholders, the people who came along, they identified as lesbian, gay and bisexual. So there was a personal invested interest as well as professional interest. And this is a big debate. And here I've got a quote from a housing services manager. She identifies as lesbian. And she says, I feel conflicted because I'm responsible for a lot of mainstream housing and care services, or partly collectively responsible for mainstream services. And I want those to be as accessible as possible. But I'm conflicted because I know that it would feel more comfortable in a place that was predominantly gay. So I kind of feel a bit conflicted professionally and personally as a result of that. And I think this person really captures that whole debate, that tension about what should our focus be. Is it about enhancing care home provision universally and lifting all standards around equality agenda? Or is it about developing choices and different ranges of care? Or is it both? And I think this is an interesting point in terms of care provision and older people's services to be having this discussion. And this gentleman, he was a stakeholder. He worked for an organisation, advocacy group, and he identified as gay. And he talked about the importance of being able to rethink care environments. So converting care environments from heteronormative spaces to spaces which are more LGB friendly, which are more inclusive. He says lots of little things, like if you feel you can't be out, you can't have a picture of your partner on public display, or openly show the other residents your life, or even take their collection or whatever. And he says that's interesting because some of the gay men said to me, you know, they were very concerned about what was going to happen to their porn collection. So just really simple things about belongings, personal items, things that are part of one's own biography, sexuality, sexual history and sexual interests, and feeling that that wouldn't necessarily be stripped away if we're having to move into a care environment. And on the same note, the importance of readdressing that culture and environment. And this particular stakeholder really captures it well in saying there's other things that are more difficult to explain, a sense of being comfortable with people, a sense of feeling that you can talk as freely as they do about things, they being heterosexual residents and staff. And your life without having to monitor yourself constantly because they're quite happy to tell you about everything that happened in their lives, however intimate. And again, referring to other residents, for example, discussing aspects of their married life or children, grandchildren. And that sense of having to monitor one's actions and vigilant of how one presents oneself was a constant theme across the sample as well. That concern that the environment in which they would be entering in terms of care provision would mean that they'd have to have a constant sense of monitoring their own expressions and actions and how they present so that nobody read them or perceived them as non-heterosexual. The final set of findings I want to talk about is with the focus groups we ran with staff and managers. We had 2 groups of managers, 27 in total, and My Home Life Wales were fantastic in helping us facilitate this. And 3 groups of care and nursing staff, groups spread across Mid, North and South Wales, so we captured services based in rural areas as well as urban centres. The thing that struck us when we looked at the focus group data was that I think very much unintentionally, as the participants were describing the care environment, they were very much describing what we saw as sexualized environments, environments which were sexually charged spaces, and there were constant dynamics and relationships around sexuality and intimacy in play. So, for example, they spoke about things like noticing that residents were masturbating in observed spaces and how they'd try and facilitate privacy for that person, and also kind of separating that person from the general care home. They talked about the flirting and sexual banter between residents and visitors, as these things were everyday occurrences, if you like. They talked about the relationships in terms of heterosexual relationships forming between residents. Again, with capacity, that was seen as something to be supported and promoted, and how sweet that was. Lacking capacity, that set off alarm bells, and that was a huge adult care issue around vulnerability and potential abuse. And they talked about the sexual contact between themselves and residents, for example, being groped as part of providing that more bodily care, physical care. So just a couple of quick quotes to put in context. This person at the top says, I've walked past someone's room and they've got porn on. So all I did was I just knocked his door and I said, you know, there's no problem with you having it on, but I'll just shut your door. And then the second person there, actually this was 2 women talking at the time about how they'd been groped before. And they said, how many times have we had our bums pinched or you've had your boobs groped as part of providing that care? So they described a very sexualised environment, although if we presented that picture or that representation to them, I'm sure they would contest to that or not be quite as agreeable to that. But nonetheless, that came through their discussions and the ways in which they depicted the environment they are working in. Right. When it came, however, to lesbian, gay and bisexual identities, they were missing, and they talked about this in the sense of it doesn't happen here, not on this floor. I've never known any residents who identify as LGB or been in same-sex relationships. So they were invisible presence, they were not recognised. Sometimes they had some assumptions. They think, oh, I think that person was gay, or I think she was lesbian. Sometimes they'd reach these conclusions in really far out ways where you just thought, wow, I don't know how you got there. But anyway, for example, they preferred talking to a woman rather than a man. Okay, so there's some potentially dodgy assumptions going on there about people's sexuality, but they didn't know anyone who overtly identified as LGB. When we talked to them about, well, what would you do if your residents were homophobic in the care environment? And unfortunately, one of the responses that came through was, more often it was about controlling the situation, supporting the person who had been upset by the homophobic response, but not challenging it. That was seen as too hard. And part of that assumption that older people are stuck in their ways, they're fixed in their beliefs and attitudes. Why would we talk to them about homophobia? Because that's just the way they are, which is really a really bleak and derogatory picture of older people as well, that somehow they don't have the capacity to rethink their beliefs or attitudes or to take on board a different viewpoint. Same in terms of racism. And this one care manager said, you can't make people behave themselves. It's their home they're living in, and they have to be able to say what they want to say. And I think we just have to sort of pick up the pieces and support the person they've upset, maybe. So that sense about that freedom of speech, if you like, it's your home, it's your space, they can say what they like. And that compromises a broader agenda about, well, what about the right for everyone to feel safe in that same environment? Limited discussion about LGB identities, limited language used when we were discussing what it would mean to provide care to LGB people. A lot of staff were aware of the historical context. They knew that discrimination happened. They knew that we had new laws coming in. The same-sex marriage bill was a big topic in the media at the time, so people were aware of that. They talked a lot about gay and lesbian staff because they weren't able to identify residents, but were often able to identify staff who were out as lesbian or gay. Not anyone bisexual, but lesbian and gay. And I just put this in because they talked about this nurse as a good worker, and he's also a great shopping partner. So very limited representation of this person. But I found this interesting because they were talking about his practice. We didn't ask them about this person's practice. But nonetheless, they talked about this staff member as being, he was a good nurse, he really was very good. And it does make me think, what would it mean if this person wasn't a good nurse? What if he's really crap at his job? Would he then be a bad gay? You know, it's just how does that fit with that particular dichotomy there? And a number of what I call rhetorical strategies for separating sexuality from discussions about provision of care and well-being. So ways of separating notions of good care from sexuality and sexual well-being. So the obvious one is about equality means we treat everybody the same. Okay, so if everyone receives the same service, has had the same discussions, we have the same response, then we are achieving equality. And as you know, we all know here in this room, it's much more complicated than that. So this person says, well, I guess I'd just be normal, isn't it? Everyone's the same, so you're just being the same with everyone. So no recognition of difference, social inequality, and how that shapes people's biographies and lives in different ways. Voiding questions, that was another rhetorical strategy, and that was about, I don't want to cause offence. I don't want to offend people in the home, or I don't want to upset people. And that was more important about avoiding that distress than actually engaging with discussions about people's sexual history. And another strategy we noticed was not actually saying LGB or LGBT, sometimes using it and them. Again, not intended to be said in a offensive manner, but nonetheless another strategy for kind of avoiding having to say it aloud. And the last finding I want to present before we start to wrap it up is that person-centred care was spoken about a lot. It's in the National Services Framework in Wales. People talk the talk in terms of we're interested in person-centred care. That's the hot agenda in terms of care home provision. But as Nolan and others say, it's an oft-quoted but ill-defined concept. And we found that people talked about person-centred care in an asexual way. So that when we talked about person-centred care, that sex and sexuality were missing dimensions. There's no discussion about sexual personhood, for example. So captured here by this particular manager, she's talking about, I might want to go to bed 10:30 and you might want to go to bed 8:30, but that's a person-centred thing, and that's what we've got to learn about individuals. And she said, I'm not going to provide a male member of staff for a homosexual resident, but they're not different. They're not going to expect those things, are they? You know, they're going to be the same as everybody else. They're going to say, well, I don't like gravy on my dinner. I like 2 sugars in my tea. Surely they're not going to come in here and go, well, I'm gay. Now, what are you going to do about it? Now, some of the women we spoke to who had been part of the feminist movement and part of the lesbian and gay rights movement, particularly in the 1970s, they were prepared to go into care homes and say, I'm gay, I'm lesbian, now what are you going to do about it? So that would be a very interesting situation there, particularly when they're not able to recognise that or see that as part of person-centred care. So I guess a very superficial understanding about what it means to respect and recognise someone's individual personhood and autonomy and wishes. But they were highly receptive. They wanted to know more. That was really reassuring, and I want to really convey that message. They were receptive to us going into the home, taking part in the study. They used it as an education session, unbeknownst to us. The manager was set up as, well, we never talk about this, so you can come in and, you know, we'll all benefit from it. So people wanted to know more. And I like this last quote. It's from a manager, and they've written this into their mission statement. Not as, in a much more refined way than this, but basically in their mission statement and the leaflets that they provide that promote the home, they have clear statements so that people looking to come into your home, you give them a statement of purpose to look at. That's another way of promoting your nursing home, to say, look, we're quite open and we'll be looking to take anyone, treat them as an individual, but there could be someone in here that's gay, and they also talked about there could be someone in here who's black and Muslim and people from different social backgrounds. And you know, if you're not as happy with that, then look elsewhere. So having a really clear statement for people outside general public that this is what you can expect in this home, and if that isn't for you, then this isn't the home for you. Just briefly on the limitations. Being a good social researcher, we best acknowledge these. There were missing voices, as I said. We didn't speak to black people. We didn't speak to many people, or have many people participate in the survey from black and ethnic minority groups or from migrant backgrounds. And again, it's really hard to unpack what that's about. Is that about gatekeepers? Is it about a reluctance to participate? Is it about our construction of the survey too? So we've got to take on board some responsibility there. And we didn't speak to residents. When we designed the study, we put this in the too hard basket in the end, because every time we thought about all the ethical and political issues that brought up about, you know, you find someone who's gay in a care home, you go into the home, you speak to them, and then we as researchers disappear back to campus. And that person's kind of left with whatever the fallout might be and after effects. And what does it mean when we start asking managers to identify residents to speak to us who are LGB? And having heard some of the assumptions they made, I think we made a good decision. I think it's a tricky one, but it's important to recognise that their voices are missing in terms of people currently receiving care. And we didn't speak to ancillary staff. And they came up to us when we had some of the focus groups, the kitchen staff, people who are involved with cleaning and domestic work. They came up to us and said, well, we talk to the residents, why can't we get involved? And of course, we didn't say no. A couple of them joined in the groups. But it's something we really didn't build in. We didn't think about that. And you think, well, you might think, duh, come on. But nonetheless, that was missing. We were more interested in people who have direct care, direct contact built into their role. And we had missing responses from the questionnaire, which I think is just the difficulty of having a self-administered questionnaire. People give up, or it's too hard, or that the subject matter is too confronting. So to finish up, sorry, I've gone a little bit over time. I will finish up now in the next 2 minutes. I think I've done enough talking. What does it mean? There's a demand for training from care homes, but we need to think carefully about what that looks like. A lot of the care home staff managers, they wanted a manual, a bit like how to fix the car, the manual that goes with the car. How do we work with these people? Can you give us some guidelines? And I think we really want to step away from that, because there's so many assumptions embedded in that. And we want to think more broadly about how we can be coming back to this notion of being attentiveness, being attuned to sexual difference. We think we want to start from a place where it's about recognising that all residents have a sexual history, have a sexual biography, and it's a responsibility there to tune into and engage in people with discussions about what that might look like and what's important to them in the here and now. from initial contact onwards. What we're not saying is sitting someone down on that initial assessment and drawing up that care plan and saying, how do you identify, or having tick boxes or anything like that. Because there'll be some people who will never come out in their care home, and we wouldn't want to put anyone in that compromising situation. But just having simple questions about, well, who's important to you, and really being attuned to the people that get nominated as part of that response. We need to rethink the notion of person-centred care, or perhaps not rethink, but widen it in terms of thinking about, well, where does sexual personhood fit in this? Particularly, it's very much established in Wales in terms of care provision, adult care, and also in relation to disabilities. So it's not going away, so we need to think, well, how can we work with this concept, with this framework, so we can get greater recognition around sexuality? We feel we need more input from critical friends, like the inspectorate agencies, and we're having ongoing discussions with the inspectorate group in Wales about this. There's a responsibility there, of course, at an institutional level. And we've got this debate about, well, should we look at lifting the standards universally? Is it about enhancing the market that we have, enhancement across the sector? Or is it about expanding the different types of provision available and giving people more choices? But then we also have to bring in terms of people's socio-economic background. That's a very privileged position to have choice about what kind of housing provision you receive, and a lot of people going into care homes have very limited choices about which care home they're going into, particularly if they're local authority funded. So we have to be realistic about that too, and think critically about who might benefit from that and who wouldn't benefit from that. And just briefly, in terms of what have we done so far, we're working with the older LGBT network for Wales that runs through Age Cymru. They've been great. They just took our recommendations and said, oh, we'll follow it up. We went, okay, you're better at that than we, because it's moving more into practice. So in collaboration with us, they're taking that forward, and they're writing to various government groups and the Care Council and the Inspectorate to follow up some of the recommendations, and really putting people to task, which is fantastic. Working with Pride Cymru, that's a third sector organisation, to develop some digital stories based on some of the narratives we captured in the interviews. We've been bringing the findings to the attention of the Old People's Commissioner, and we're keeping that discussion going. We've also been talking with housing providers as well about what this could mean in terms of their future provision. And Diolch yn fawr, thank you for listening. Appreciate that. That's